Hi, Dr. Clomax. It's Tony Cool in admissions. I'm just going to suggest to go ahead and get started because generally we have a 50% attendance versus RSVP. So
Sure thing. Sounds
thank
good.
you so much.
No problem. Thank you for having me, and thank you for taking some time out of your Thursday. I started to say Wednesday. It is Thursday to spend with me. So let me go ahead and share my screen here. Let's do this. Okay. Everybody can PowerPoint and see me okay?
Yes, yes.
Awesome, perfect. Okay, so let's go ahead and get started. So I joke that I probably should have gotten a degree in linguistics, considering how much I love language and how important I think it is. I think it's really just important to be mindful of the ways in which we are communicating ourselves and to be intentional about the words that you use. Especially as a forensic practitioner, our primary means of communication are the reports that we are sending to court. And so it's important that we are accurate and appropriate in the ways that we are describing and talking about our clients. So we'll talk a little bit about the ways in which you can destigmatize your documentation. All right, so let's kind of sort of briefly discuss sort of the scope of the issue, kind of where this comes from. So this has been, I would say, something that is really heavily researched in social psychology. And I think recently, I want to say maybe within the last decade or so, it's kind of made its way over into the sort of healthcare setting. And so there have been a lot of studies done by physicians and other medical professionals regarding the ways in which they utilize language to talk about their patients. So this is a study that was done in 2017, and essentially they wanted to examine the language that physicians use when they are communicating disbelief about their patients. So when you go into the doctor's office and you're talking about your symptoms and the doctor isn't really believing you, how do they go about communicating that disbelief in their records, in their patient's progress note? So these were patients that had been seen in an academic ambulatory internal medicine practice. So kind of think of like Northwestern, like a large kind of medical practice hospital. They reviewed 600 clinic notes, and they essentially came out with 3 themes in which physicians communicated disbelief. So one of the themes is that they noticed that physicians heavily utilize quotations around words that they didn't necessarily agree with or believe with their clients. So Ms. Doe says that she had a reaction to the medication. The word reaction would be communicating, or having it in quotations would be communicating disbelief. They use judgment words. So John Doe claimed, that his chronic back pain got worse, or John Doe insisted that the medication was not working, using words like that. And then the third theme was something called an evidential. An evidential is essentially the way that the physician would construct the sentence. And the way that the sentence is written in a way that communicates that whatever the patient reported is actually hearsay. So it's like gossip. So that was another way that they communicated disbelief. So what they found was that notes that were written specifically about Black patients had higher odds of containing at least one quote and at least one judgment word, and more evidentials compared to white patients. A more recent study, this came out, I want to say last year or early this year. So another similar study where they wanted to identify and describe physician language in patient health records that reflected negative or positive attitudes about the patients. So they looked at notes from EHR systems from, again, like very large kind of ambulatory internal medicine practices. They looked at about 600 notes that were written by 138 physicians. So of the 600 notes, there were 5 themes that they pulled. First, they noticed that a lot of the notes were written in a way in which the physician questioned the patient's credibility. Another theme is that they noticed that notes were written to express disapproval of the ways in which patients chose to take care of themselves. So a really good example is that sometimes I'll have clients in practice who will talk about ways in which they deal with their anxiety or lack of sleep, right? So like, let's say a client is explaining that, yeah, I've just had a really long, stressful week and I got home Friday and decided to have a glass of wine. A way to express disapproval, right, in the progress note would be like, you know, Jane Doe said that she decided to have a glass of wine. Physician does not agree or something like that, right? So like not agreeing with the ways that our clients choose to basically take care of themselves. They would utilize language that stereotyped patients by race or social class. They would utilize language that portrayed their patient as difficult. And they also emphasized or wrote their notes in a way that emphasized authority over their clients and their patients. Okay. So what is stigmatizing language? You can think of it broadly as sort of markers or identifiers that are sort of based in discrimination that is used against an identifiable person, group, or nation. So they're not necessarily personal preferences, but they are things that have sort of been developed from social constructs that we create about groups of people. So you could think about it in the ways that, you know, we create stereotypes about people, particularly minoritized communities. We then internalize those stereotypes, and then those stereotypes turn into implicit biases. So when you see a particular person, you automatically have sort of an opinion about them or the group in which they represent. So stigmatizing language generally takes three forms. So marking or labeling somebody as an other, assigning responsibilities. So for example, typically a lot of time what you see in substance use is a lot of the stigma is blaming people for having addiction as opposed to describing that it's someone who's struggling with addiction. So you'll see a lot of blame being put on people who struggle with substance use. It's like, well, you're 100% responsible for your problems. And invoking danger or peril. So you can think of the stigma regarding a lot of Black men, right? That Black men are somehow like more dangerous or more aggressive or just savage compared to any other group of people. So other examples, labeling people as substance abusers rather than substance users. Patients that are being described as like non-compliant, I hear that a lot, or poorly controlled, or again, emphasizing that the person is 100% responsible for their illness without taking into account that oftentimes as people, especially living in this country, like we have to navigate a lot of oppressive systems, and those oppressive systems are also entangled within whatever it is that we're presenting with. And so also labeling like distressed patients as like belligerent or out of control or combative, or implying that somehow people are intentionally trying to hurt staff or things like that. Another really popular one that I see is there was actually a workshop I attended some years ago, and the presenter was saying that typically in forensic reports, you want to stray away from using the word denied, because denied implies that if you have, like, let's say you ask a client a question and they give you an answer, but that answer is not consistent with their medical records. So you use the word denied, that can imply that the person is lying. And so really kind of being mindful of using language and words like that, because we don't want to, you know, present to the court that the person is lying. That's not our intention. So does language matter? You can probably presume that given this presentation, I'm going to say yes. Yes, language does matter. Language uncovers bias, right? Going back to those sort of internalized stereotypes. You know, oftentimes I'll see or hear people refer to Black people as a Black, right? And it's like, well, a Black what? Like a Black woman, a Black man, a Black human being? What do you mean? One of my huge, like, grinds my gears is when people, typically men, I often hear referring to women as females. Now, I think sometimes in progress notes or in like clinical documentation, we tend to use male or female like to identify someone like biologically, right? But oftentimes in social settings, the word female is typically used derogatorily. And it's like, well, a female what, right? A female bird, a female dog. Like if you're referring to a female human being, there is a word for that, and it's one. Or using terms like Oriental, sometimes like back in the day, I would hear, you know, referring to like the Asian community. And then, you know, I think most recently kind of with everything that is going on with violence against trans people, there are a lot of derogatory sort of language for the LGBTQ community that I'm not going to repeat, but I'm sure you've heard it. So essentially, you know, language like this denotes, it others people. It denotes that people from minoritized communities are somehow subhuman. It's also no surprise that patients are not patients from minoritized communities are not treated equally within our healthcare system. And so there's a lot of research that is consistent with the fact that they oftentimes receive poor quality of care based on other people from other sort of racial or ethnic communities. And so when you kind of couple that with implicit biases, right, it becomes a lot more apparent which groups are going to be more targeted by that. So you can think of implicit bias as the automatic activation of those like internalized stereotypes or stigmas that we have about groups of people. And they tend to override sort of deliberate thought and influence. And they're automatic, right? They're very quick. And so if you are not aware of your own personal biases against groups of people, then you're going to be less likely to call yourself out when it's needed, or you're going to be less likely, you're going to be more likely rather to overlook the language that you are using to describe certain groups of people. There's also stigmatizing language that is used with older adults, people with low health literacy, people who struggle with obesity, people, again, with substance use disorders, and all of these groups of people, the research tells us, are consistent with receiving kind of poorer care in the healthcare system. So some examples. So this particular Park study from last year had extracted some quotations from physician notes. So apparently he was sitting at home on the floor feeling fine when suddenly he felt fatigued all over his body, right? That denotes a very specific, like, a tone, versus Mr. Doe said that he was sitting at home on the floor feeling fine when he felt fatigued all over his body, right? That sentence sounds very different when you remove apparently and suddenly. Or using words like insist. Ms. Doe insists that she gets sick from vaccines versus Ms. Doe reported she gets sick from vaccines. Two very different tones. He claimed it was fluid from his knee, or she takes albuterol for chronic bronchitis. The issue with the chronic bronchitis being in quotes is that it sort of goes back to this idea that our patients, our clients, are not aware of what their own symptoms are. And so it further goes back to that kind of disbelief that we are not listening to and believing patients and clients when they're coming into our office and telling us what it is that they're experiencing. So this Park study also denoted sort of other categories. So again, going back to the credibility, so the implication of sort of not believing your patients or their experiences. A lot of the notes highlighted disapproval. So not agreeing with the ways that our patients, our clients are choosing to take care of themselves, kind of going back to that wine example that I gave. Stereotyping. So there's a difference between specifically quoting what someone says, especially if they are speaking a different language, or maybe they're using like words that you're not familiar with, or they come from a very specific community that kind of has their own language, like AAVE. And then there's a difference between like quoting them directly and then sort of using their language as if it's your own. Those are two different things, right? Like if you don't speak AAVE, or if you are not fluent in AAVE, probably don't want to be using it in your progress notes unless you're quoting your patients directly. Identifying people as difficult or belligerent or combative, and unilateral decisions. So language that emphasizes that you have authority. So I told Ms. Jones to do this, or I instructed Mr. Doe to make sure that he did X, Y, and Z. So then what happens, right? So we have this internalized bias, which leads to poor health outcomes. So again, a lot of this sort of started within the social psychology kind of community, and it's slowly finding its way over into the healthcare setting. So there was a study that had been done of emergency medicine physicians who found that physicians who were using the word sickler to identify patients who had been diagnosed with sickle cell disease were more likely to have progress notes that contain bias. And then, of course, that biased language can then turn and affect the attitude, the way that the physician treats the client in the room. There was another study that was done that found that physicians who read a vignette with the term substance abuser, as opposed to describing the person as having the substance use, agreed more that the person was personally culpable and responsible and should be punished, versus someone having a substance use disorder. They were less likely to think that. So again, research consistently supports that there's increased mistrust from people who come from minoritized communities within the healthcare system. And so a lot of times, people aren't stupid, right? Like our clients are not unaware. They can pick up on the fact when they're being judged, when they're being talked about. They can pick up on the fact when they are in a room with a physician and the vibe just doesn't feel right. Like people internalize those things, they can feel those things. So they're going to be less likely to seek treatment in the future because of that. So another study done in 2011 wanted to estimate unconscious race and social class bias among first-year medical students, specifically using the implicit association test. Many of you may be familiar with this test, that it basically assesses, like, do you have preference for different groups of people? It's a phenomenal test. If you haven't taken it, I would highly encourage you to take it. But essentially, they administered the IAT to assess unconscious preferences. They utilized direct questions regarding explicit race and social class preferences. And they also developed 8 clinical assessment vignettes that focused on pain assessment, informed treatment, patient reliability, and trust. What they found was that among the 200 students who completed the survey, the IAT responses were consistent with an implicit preference toward white persons. And so their responses were also consistent with the preference toward those who were upper class. So you can kind of picture, given our sort of diverse society, the majority of us are not white and upper class, right? When we sort of take that within a forensic context, the majority of the people who are court involved or justice involved are Black and brown people. So if your implicit biases are those that are favoring or preferring white upper class people, what does that say about the people that you are more likely going to come into contact with on a daily basis? Another study found evidence of implicit bias amongst healthcare professionals. So there was a negative correlation that existed between the level of implicit bias and indicators of quality care. So a negative correlation basically means that the more implicit bias someone had, the less the quality of care was. So physicians and nurses essentially manifest these implicit biases to a similar degree as the general population, which isn't a surprise because they are a part of the general population. I think the majority of us, right, have implicit biases, but again, it's important to be aware of those biases so that you can check them. So what they found was that biases were more likely to be elicited from people who were of minoritized communities. So race and ethnicity, gender, lower SES, older age, people with mental illness, people struggling with obesity or having been diagnosed with AIDS, brain injured patients, those with a disability status, as well as those from non-privileged circumstances. So now that we kind of have an understanding of the problem, it's important to sort of be mindful and intentional about what do we do with this information going forward. So I would argue it's really important that you prioritize person-first language. So what is that? Person-first language is the intentionality of wording things in a way to show that your clients or your patients have a problem rather than identifying or signifying them as the problem, right? Two distinct things. It avoids eliciting negative associations or like punitive attitudes about people or putting blame on any sort of one person, group, or community. So couple of examples. So one of the things that I try to urge students to do that I model myself is that, especially in a forensic context, making sure that we're referring to people as justice involved or court involved instead of offender or inmate or criminal. If you're working in substance use, right, this is a person in recovery, not an addict. This is a person who uses or misuses versus abusing. This is a person who tested negative versus clean, or a person who tested positive versus dirty, right? Being very intentional about your word choice. Park also identified some other alternatives to those categories that we talked about before. So there's nothing wrong with complimenting your patients or your clients, right? Talking about them very highly. One of the things that I do in my evaluations of people is when I'm doing my MSc and I'm explaining what it was like sitting with this person, I let the court know, like, Mr. Doe is very polite, very charming, or very easygoing, or nice to talk to, right? Something that denotes that this person was, that they presented positively. highlighting patient knowledge or their reasoning skills or the ways in which they choose to take care of themselves. So even, I've got some clients who are not very sort of particular about wanting to take medication for, their symptoms. Totally fine. That's not like a new thing, right? But making sure that the way that I denote that in my note really emphasizes that they have the responsibility to choose how they want to go about dealing with their anxiety or their depression or whatever it is that they are diagnosed with. Physician self-disclosure of their own positive emotions. So happy to work with this person, or it was a pleasure to meet so-and-so. Making sure that we are minimizing blame in our documentation. So one of the ways that you can do this is just explaining why someone chose to do something. So for example, Mr. Doe decided not to take the Klonopin that was prescribed to him because he doesn't like the side effects, or the side effects are too severe, right? That is a great way to minimize blame. It really explains why the person is taking ownership over their own healthcare. Being able to incorporate details about the patient that they, are an autonomous being, and that they do things that have nothing to do with what they are presenting with, right? So, Mr. So-and-so is an entrepreneur, or they sing, or these are their hobbies, or things like that. And also making sure that you are writing notes that reference the collaboration or the holistic sort of relationship that you have with your client. So Mr. Doe decided that they didn't want to take the medication. So we will reassess this at a different time, right? As opposed to writing it in more of a derogatory or negative manner. I would also highly encourage you to utilize the EDI guidelines that were just developed by the APA. It's a sort of full document, but they basically define and identify inclusive language for various different diverse communities. And they also provide recommendations for making sure that you go about avoiding microaggressions in your speech. So very, very, very well put together document. Another thing as a field is moving toward this kind of open records sort of movement. So the 21st Century Cures Act was signed in 2016. It was developed during the Obama administration, signed by President Obama. But it's basically an act that requires that patients be given electronic access to all of the information in their medical records. The regulations for implementation of this law is that the idea is that it gives patients far easier access to their own information, including the notes that their clinicians are writing about them. So what is an open note? Basically a summary of what you told your doctor, your nurse, your therapist, any findings from a physical exam, especially if you're seeing a psychiatrist, so blood pressure, weight, all that type of stuff. Your provider's thoughts about the results of any lab tests that came through, a summary of thoughts about any medical conditions or symptoms, and any recommendations regarding your treatment plan or aftercare. So there was a study done to kind of assess the attitudes of the sort of healthcare community and kind of how they felt about the sort of open notes process. And interestingly enough, only about 75% actually agreed that it was a good idea, which is a lot, yes, but there's still that kind of 20% of like, I wonder why there is no agreement with the open notes movement. This movement, or rather this study also found that because of the Cures Act, that physicians reported spending more time on their documentation, which is great. That's exactly what we want, right? We want people to sort of be more thoughtful and intentional about the ways in which they are communicating with their clients. Many reported specific changes in the way that they write their notes, also good. The most frequent of which was related to the language that they use to talk about their patients. So it's kind of this idea of, if your clients had access to your progress notes, would that change the way that you wrote them? And hopefully the answer is yes, because it should. So just some sort of thoughts or self-reflections or things to kind of walk away is, when you're writing notes, when I write documentation, whether it's progress notes, reports for the court, I kind of write it as if the client is standing over my shoulder. Right? What would my client think about the way that I'm talking about them? Would I want to be described this way? Is there a better way to convey my thoughts? Would I feel comfortable if my client requested their progress notes, which I've had clients do, would I feel comfortable if the report that I'm writing, even though it's going to the court, would the way that I wrote that report change if I knew that it was going directly to the defendant first? And how can your progress notes negatively impact the therapeutic relationship if your clients were able to, or not able, they are able, if your clients requested them, how would they negatively impact the therapeutic relationship? So in a nutshell, as I always like to say, words mean things. So you want to use them wisely, make sure that you are very intentional and thoughtful about the ways in which you are utilizing language to communicate yourself, your thoughts, and to talk about your clients. And that is it. Any questions?
Any questions for Dr. Clomax here? You can either just unmute yourself or put it on the chat box and I can read that for her.
Thank you, Silas. No questions?
Can I ask one?
Good thing or a bad thing? Oh, go ahead.
You touched on it briefly, but the use of quotations in an effort to like get someone's direct language, right? Do you think that's really only used if it's not like common knowledge what that means? Like that example of chronic bronchitis. I'm just curious if you could speak to that, especially in like maybe a private practice setting, a therapy practice setting.
Yeah, and forgive me, so my camera's here, but I'm looking at you here. That looks weird. So the way that I was sort of trained and the way that I tend to use quotations is if I am directly reporting what the client said, like word for word. So sometimes what I'll do is, like I've had clients who maybe they use the wrong word or they slip up or they meant to say this or they said that. When I'm typing it up, I will put in brackets like what the actual word is or what they meant to say so that the court knows that this is my language and not the client's. I think sometimes, you know, quotations can be used to effectively kind of identify what people are saying, but the problem is when we're looking at the entire way the sentence is constructed, right? So like chronic bronchitis in and of itself, it doesn't necessarily mean anything, but when you put it back into a sentence in which that sentence is constructed in a way that denotes disbelief, then that changes the meaning of it. I hope that answers that.
It's helpful. It's, you know, a continual balance, right? To
absolutely
get what the person's giving you and also make sure you're relaying that in a way that's helpful to them.
Exactly. Any other questions?
I mentioned earlier, Dr. Clomax, before you join it, I will be sending them a copy of your PowerPoint, and this is recorded as well. So if there's anyone who missed the earlier part, I will be more than happy to send you the recording as well.
Well, that's all that I've got.
Okay, great. And thank you for you know, having this faculty spotlight event for us, Dr. Clomax. And thank you all for attending. My little announcement here as well is that our next faculty spotlight is going to be with Dr. Jason Dana. That will be on June 1st at 12 noon. And his presentation is about treatment, you know, competency restoration and treatment units in jail facilities. I will send you also the link to the next event. So hopefully we all see you back again.
Awesome. Well, thank you so much.
Thanks again, Dr. Clomax.
Bye.
Have a great afternoon, everyone.